My dear viewers, in this video, I am going to discuss about the different post-operative fluid management strategies in the various surgical ICUs. It's of our common knowledge that post-operative patients need fluids, and a lot of times these fluids are required in calculated amount and also the desired quality of fluid to achieve hemostasis, to prevent vascular disintegration, and also to promote wound healing. So, depending upon the consequences, the extensiveness of the surgeries, the fluids have to be chosen, and a clear understanding of the various fluid compartments and their possible variations in the event of surgery should be understood for fluid therapy, for guiding fluid therapy in the surgical ICUs. Let us look into a case. A 50-year-old male, a BMI of 26, with no comorbid illness, is admitted with acute and chronic intestinal obstruction for 2 days. The patient undergoes emergency laparotomy with resection and anastomosis. The duration of surgery lasts for 3 hours. There is an intraoperative loss of 600 ml, and patient receives intraoperatively 2 liters of crystalloids and 2 packed RBCs, and is shifted to the ICU on ventilator, partly because of hemodynamic instability and partly because of inadequate reversal. And after shifting to the ICU, the patient records a BP of 110/60, heart rate of 110. Patient is deeply sedated. The saturation is 98%, and the urine output is 100 ml per hour. Now, which fluid should you use in such patients? Now, it is important to recapitulate some of our basic understandings of the fluid compartments. Like if you assume the weight of the patient to be 70 kg and the total body water is 60% of the body weight, so that becomes around 42 liters of fluid. Out of this 42 liters, the extracellular fluid volume is 1/3 of the total body weight, so it is 14 liters. And the intracellular fluid volume is 2/3, so that is 28 liters. Now, out of this 14 liters of extracellular fluid, about 1/4 is in the plasma and 3/4 in the interstitial spaces. So that makes around 3 liters and 10.5 liters. And of course, little bit of transcellular fluids needs to be counted, which is present in very minor amount. So this is the apparent distribution of the total body water in the body. And any distribution of the fluid takes place in a particular relationship to this distribution of water, depending upon its content. If you look into the cations into these different compartments, if you look into the plasma and interstitial fluid, we find that the predominant cation is sodium and the predominant anion is chloride, with lesser amounts of phosphates, sulfates, or bicarbonates. In contrast, the intracellular fluid, the predominant cation is potassium, and the predominant anion is phosphate and the sulfate, and the bicarbonate is less. In addition, we can also see that the protein is also high in the anionic form, is also higher in the intracellular fluid as in contrast to extracellular, that is either in the plasma or the interstitial fluid. Now, this understanding is also important because the various fluid shifts are determined by the passage of the water as well as the ions. Whereas the cell membrane is permeable to water, it is not always permeable to the ions. For example, the sodium potassium ATPase that tries to expel the sodium outside the cells, whereas it tries to retain potassium. So likewise, a shift in the fluid depends to a large extent on how much of these cations are present and in what concentration in the infusing fluid. Therefore, if you look into the composition of the commonly administered fluids, we can see this differences with the differences in the compartments that they exist, and that creates a gradient based upon which the movement is determined and their distribution happens. And another important thing is the osmolality, that is the osmotically active particles present within the fluid. And if you see that there is a lot of times there is difference between theoretical osmolality and in vivo osmolality. Like in normal saline, the theoretical osmolality is 308 because of 154 each of equivalents of sodium and chloride. But in vivo osmolality is often less. And the in vivo osmolality is less because some of these osmotically active particles may not be actually freely permeable, and they may not be responsible for creating the gradient. So whenever we decide upon a fluid and we decide upon its tonicity, we will also have to take cognizance of its in vivo osmolality rather than the theoretical osmolality. So whenever we use a fluid, if it is isotonic, it will always get distributed in a way it is distributed in the plasma according to the composition of the plasma. Now, what exactly happens to the fluid balance of the after surgery? Now, earlier people used to think that a lot of fluid, which is besides than one which is lost during bleeding, drainage of ascites, urination, insensible water loss, there is a lot of third space loss, and this third space loss occurs because of shift of fluid from the vascular and the intracellular compartment to the interstitial spaces. And it was believed that in order to compensate that loss, one has to give more fluids, and even more was considered to be less. But later on, it was seen that the adverse reports came in front, and it was understood that it is not more is less, but it is less is actually more. And therefore, a careful monitoring of the fluid status became of vital importance while administering fluid to these patients. Now we know that the third space fluid or the third space loss is now considered to be a myth in clinical practice, but still a large group of uh, practicing physicians do believe third space loss exists, and they account the fluid that is present in the bowel lumen, peritoneal, and pleural cavities to be responsible for the third space loss. So what in fact that is true is that third space contains all types of fluids that exist in spaces where they do not contribute to the maintenance of the fluid balance between the compartments. And one term has been used besides third space, it is called the functional extracellular fluid volume. And it measures the functional extracellular fluid volume is the fluid accumulations within the interstitial space combined with plasma. And this, when the third space loss measured this extracellular volume and the functional extracellular volume. And it is seen that the current evidence supports that the overhydration with saline and surgical trauma actually causes endothelial dysfunction and interstitial edema due to a fluid shift to the extracellular fluid volume without affecting the functional extracellular fluid volume. So the FECV doesn't change after surgery, but ECV changes. And it is very important to realize also that the earlier concept of osmotic or interstitial of hydrostatic pressure creating the gradient and driving the pushing the fluid out versus osmotic pressure trying to retain them is also finds no place today, because the osmotic pressure is found to be several fold higher in the intravascular compartment, but yet there is no edema. So it is believed that it is the glycocalyx which dysfunction of which leads to the loss of vascular integrity and the leakage or fluid creep from the intravascular compartment to the interstitial spaces. So we have to understand the goals of fluid therapy after every surgery, and we have to fix our vision towards these goals, that is restoring and maintaining the tissue fluid and electrolyte hemostasis and central euvolemia, which means there should be adequate blood volume in the vessels and in the central compartment, so that there is adequate perfusion while avoiding salt and water excess. The primary maintenance IV fluid for all major surgery should be an isotonic balanced crystalloid. Why so? Because then the distribution of the fluid will be in conjunction or in concurrence with the distribution of water, so that the spread of fluid will go primarily to the intracellular and the intravascular compartment, with lesser amount going to the interstitial spaces. And functional extracellular fluid volume, which is defined as fluid accumulation within the interstitial space combined with plasma, has very limited role because it is usually does not disturb until the endothelial, the glycocalyx is affected or is disintegrated. So, depending upon the surgical risk and the patient risk, if both the risks are low, then goal-directed therapy is not indicated, but the aim should be to maintain 1 to 2 liters of positive fluid balance. Whereas, if either the patient risk and surgical risk are both high, or if the patient risk is high and the surgical risk is low, or the surgical risk is high at the patient, in all these cases, goal-directed therapy is recommended so that there is no excessive accumulation of fluid leading to metabolic derangements due to any cause. When the risk is high, the patient should be considered for admission in surgical ICU or in ICU, so that goal-directed therapy can be more meticulously, more carefully planned and performed. Now, why dextrose containing fluids are used following surgery? Now, IV fluids should be sodium poor and of low enough volume when redistribution occurs, because after surgery, all that fluid that had escaped from the central compartment to the peripheral compartment, that they start returning. And in these cases, we should give once those fluids which will be more easily distributed to the peripheral compartments to meet the required energy needs. So that is why IV maintenance fluid should be sodium poor. And in patients who are edematous, hypovolemia, if present, must be treated, followed by gradual persistent negative sodium and water balance based on urine sodium concentration or the urine sodium excretion that we have to monitor. In high-risk patients undergoing major abdominal surgery, post-operative treatment with IV fluid and inotropes should be considered so as to achieve adequate tissue oxygen delivery. We have to remember that even if the upstream parameters or the upstream markers are normal, it does not always ensure adequate tissue oxygen delivery. So, in order to tissue oxygen delivery, it may be important to give inotropes alongside IV fluids, and for which the downstream markers like lactate, etc., should also be monitored. Those patients who fail to excrete their perioperative sodium load, and especially whose urine sodium concentration is less than 20 millimoles per liter, they should be reviewed and monitored for overload. So, in patients who are euvolemic, who are hemodynamically stable, the surgery is not extensive, the risk factors are not there, the surgical risk is also less. All these patients, the aim should be to return them to oral fluid administration as soon as possible. Let us look into the second case. A 55-year-old male, diabetic, hypertensive, admitted with headache followed by loss of consciousness for a day. The CT head finds an MC and aneurysm bleed. Patient undergoes craniotomy and clipping with an external drain and is shifted to the ICU. The patient is put on elective ventilation in the postoperative period alongside ICP monitoring. Now, which fluid should you use? We have to understand that out of all the fluids, the crystalloids are the choice in patients with neurosurgery, for the simple reason that they do not tend to accumulate quickly, and they are dispensed by the body in no time. So normal saline is widely used in neurosurgery because it is thought to reduce the risk of cerebral edema. Hypotonic solutions like ringer lactate is, although it is considered as isotonic, but if you look into the actual in vivo osmolality, then it may be considered as hypotonic. They should be avoided in neurosurgical patients to minimize cerebral fluid accumulation. A decrease of 1 milliosmol per liter in the plasma osmolality results in an increase of 19 millimeter mercury in the pressure of fluid movements across the blood-brain barrier. and a 3% decrease in the plasma osmolarity results in cerebral edema with a 3% increase in the brain volume and 30% increase in the intracranial blood CSF volume. So we can see how intense is or how high are the risks of cerebral edema if we administer hypotonic solutions. So these solutions are avoided. Isotonic balanced solution is preferred over your normal saline in neurosurgical patients because of the lower risk of metabolic acidosis and renal injury, which can occur with excessive administration of normal saline, both hyperchloremic metabolic acidosis and the chloride-induced acute kidney injury. So isotonic balanced solution, although the long-term effects may be similar, but for the initial insult may be slightly less if isotonic balanced solution is used. We also have to know what causes the cerebral edema after fluid administration. Now, cerebral edema results from a combination of endothelial cell damage, tight junction disruption, and abnormal transcellular transport. They can be partitioned into three categories. One is because of the vasogenic, which is the vasogenic edema, the cytotoxic edema, and the interstitial edema. Now, of this, vasogenic cerebral edema is the most common type of brain edema, and it originates from the because of the increased permeability of the capillary endothelial cells and accumulation. So 1% increase in brain water content is equivalent to 4.3% increase in the brain tissue volume. Brain water content of tissue surrounding the resection site increases by 3% or more during the first 72 hours after surgery and resolves slowly within a week after surgery. So during this entire period when it is inflamed or where the resolution has not been complete, there will be a risk of edema, and one has to be particularly careful while while administering fluid in such patients. What should be done if the patient develops diabetes insipidus? Now, this is again a common feature in neurosurgical patients who tend to develop diabetes insipidus either following head injury or pituitary or thalamic hypothalamic lesions, and in whom the main clinical features are polyuria, that is more than 5 ml per kg per hour in an adult or more than 200 ml per hour, which results in dehydration and hypernatremia. So the patients should receive maintenance fluid plus 3/4 of the previous hour's urine output in each case. Alternatively, the previous hour's urine output minus 50 ml should be administered of free water. The fluids administered should have a low sodium load as half strength to normal saline and D5W. When the urine output is more than 300 ml per hour, at least for 2 hours, vasopressin can be given at 5 to 10 international units. Alternatively, desmopressin can be also used 0.5 to 2 milligram IV at 8 hourly or by nasal inhalation in 10 to 20 mg. Let us go into the third case. A 25-year-old multigravida, 32nd week of pregnancy with seizures and hypertension for a day, had ankle swelling since early pregnancy, and after stabilization, whose pregnancy has been terminated by a LSCS, is shifted for elective ventilation in the postoperative period. Her heart rate is 120 per minute, blood pressure is 170 by 100, urine output is 20 to 30 ml per hour. Patient is sedated. The magnesium levels monitored are within the normal range. There is no active bleeding. The question again, which fluid should you use? Now, all these patients who have preeclampsia or who have eclampsia, that is, have seizures, they have a high risk of going to the pulmonary edema. So now this pulmonary edema being because of increased preload, that is excessive IV fluid administration or resolving purpural peripheral edema. They can be because of cardiac causes like myopathic ventricle, diastolic dysfunction, and valvular heart disease, increased afterload because of severe hypertension due to increased SVR, or other factors like reduced oncotic pressure, increased capillary permeability. However, most commonly, they can have a combination of factors of all of these, and of this excessive IV fluid administration is purely iatrogenic. Therefore, monitoring the administration of IV fluid in eclampsia is very important. So commonly the maintenance therapy which is required in these patients is commonly given slowly over 24 hours and may be calculated to match the urine output plus the insensible loss. The clinical markers of euvolemia may be inaccurate in women with eclampsia. because oliguria may develop because of intrinsic renal disease, including acute tubular necrosis, and may not respond to the plasma volume expansion with an increase in urine output. So that can be misleading and may not be a perfect clue. Use of CVP monitoring may be dangerous because boluses of fluid may lead to sharp increase in PCWP and even before any rise in CVP is observed. So that can also lead to cardiac failure. So all patients who receive IV fluids in more than maintenance doses should also be monitored using pulse oximetry, because that is the gadget which may allow early detection of pulmonary edema by showing fall in the saturation even before other things manifest. Now, what to do if the patient is oliguric? If the patient is oliguric with a positive fluid balance, 300 ml of isotonic fluid challenge can be given. If no response, restrict fluids to match the losses. If oliguria continues, we give vasopressors, and we also consider invasive hemodynamic monitoring. If the patient has oliguria with negative fluid balance, again 300 ml of isotonic fluid challenge, and that can be repeated every 30 minutes until patient is in positive fluid channel or adequate urine output pours out. If persistent oliguria, we have to restrict fluids. If still oliguria continues, give vasopressors and consider invasive hemodynamic monitoring. Definitely in these patients also we should consider for an early renal replacement therapy, provided the other factors are there are no other contraindications. Now, what are the differences in fluid resuscitation between eclamptic patients versus normal hypovolemic patients, who are more common in the post-surgical period in gynecology? The focus of resuscitation should be on restoring the systolic blood pressure to more than 90 millimeter of mercury, with less attention paid to urine output and heart rate as a guide to establishment of euvolemia. Initial resuscitation with clear fluids should be superseded by blood component therapy so that the adequate osmotic pressure is maintained, and the possibility of overtransfusion and pulmonary edema should be considered once the systolic pressure has been stabilized, and any further fluid therapy should be based upon replacement of losses or should be guided by appropriate hemodynamic monitoring. So the rapid and adequate restoration of renal perfusion may be the only opportunity of preventing acute kidney injury in such patients, because as we know, they may already have a badly damaged kidneys or at least some amount of kidney dysfunction. So following surgery, if balanced crystalloids have to be administered, if the AKI risk, or if the patient has an IV fluid volume of more than 2 liters, in which case we prefer lactated ringer solution or plasmalite A, etc. In sepsis, we administer balanced crystalloids, either lactated ringer or plasmalite. Traumatic brain injury, you usually go for normal saline. However, in special cases, if the patients are having diabetes and DKA, we need to monitor the diabetes closely and the electrolytes before deciding upon the fluids. In renal dysfunction and severe hyperkalemia, we have to administer fluids which do not have potassium. With abnormal sodium levels, we will also have accordingly match the presence or excess of sodium. And for abnormal acid-base balance, we have to avoid fluids like normal saline, which can cause hyperchloremic metabolic acidosis. So the final take-home message would be the management of post-operative fluid therapy should be done considering both patient's unique status and the intraoperative events. Intraoperative events leave behind a clue on the basis of which the actual management should follow in the post-operative period. However, there is tendency towards empirical fluid management, which can be replaced easily by evidence-based strategies. Goal-directed supplementation is the most rational approach to assess the patients and maintain optimum fluid balance, but for them it is important and essential to monitor the vitals accurately and add fluid and order fluid to maintain the volume plus the losses. The debate around colloids and crystalloids should also be considered, although colloids are usually not preferred in any post-operative setting unless there are very special reasons for using them. They are not used. But more importantly, the advantages and disadvantages of each solution should be evaluated against the specific condition for which fluid is being administered in the postoperative period. Thank you very much.